Hi, good afternoon. Thank you, Dr. Skarnsiva, for giving me this opportunity, and I'd also like to thank the Vasculitis Foundation for allowing me to talk about this very important topic for the patients. So we will get started. I do not have any disclosures. Basically, we're going to talk about these three major things. We're just going to discuss the relationship that patients have with steroids. We will talk about the most concerning side effects from a patient perspective. The side effect list is very long, and we will just only be talking about the most common ones. And briefly, how to prevent and limit these common side effects. So by definition, what is long-term steroid use? It's usually defined if you are on steroids for 3 or more months, and the dose is generally if you are on a dose higher than 2.5 milligram for that period of time, which ends up being most patients that are sitting here. So how do we describe the relationship between patients and steroids? It's one of relief, fear, hope, and uncertainty. So if you look at this graphic here, looking at the left side, we can see that when patients are diagnosed, they are happy that at least they have a diagnosis, because many times it takes a long time before they're actually diagnosed with this condition. And then when they start the steroids, they tend to get response rather quickly, which is, again, a very good thing. But at the same time, they start experiencing side effects, which in the short term and then the long term, and then they hear stories about steroids and they experience them themselves too, which kind of creates this conflicting situation where you're having some benefit from the steroids, yet you're having problems with them. And as the disease course goes, and as you move to the right of the screen, and now you have a chronic disease state, and you are on steroids, you're doing really well, but then you're still concerned what is going to happen to you. You're already having side effects, and you may be having progressive side effects, so that's a major concern. But on the other hand, the patients are worried. How will they do once they reduce the prednisone dose, or if they go off of it completely? Will they have to start the whole cycle again? Will they be able to do it at a lower dose or not? So those are all valid concerns that patients and physicians share in a journey of patients who are on steroids. So just a patient perspective, hope and relief, this is from a study. This is a patient with GPA from the UK, and that's what they said. I came in here on a Friday, I could not walk. I started the steroids on Saturday, and on Sunday I was walking down the ward. So these are really effective treatments. But there's uncertainty associated with it too. So just in a patient's perspective, it was clearly unknown what was going to happen if I tried to get off of it. It was just an experiment. I think it was done with the full understanding that if it did not work, I was ready to go back on those steroids, and that's exactly what happened. So side effects from steroids are very common. 86% have had at least one adverse effect. So this graph here lists the number of adverse effects in the left column, starting from no adverse effects up to 7. And the column on the right is number of patients, not a percentage, and it's a total of 120 patients. So you can see there is a wide variety, with the most common being one side effect. But if we look at the cumulative numbers, 86% have had at least one side effect. There were 10 patients who had 4 side effects or more, and there were 17 patients who had none. So what does this tell us? This tells us that it is hard to predict what side effect and what patient will get the side effect. It depends on what disease you have at your baseline, what dose of steroids you take, for how long do you take the steroids, and then what are your pre-existing conditions. So if you already have diabetes, or if you already have osteoporosis, or if you already had serious infections, then you're likely to have more side effects. So it is a very patient-centered way of saying what will happen, because it just depends on the patient and the existing conditions. So it's hard to predict how every individual patient will do with these steroids. So as I said, they have a long list of side effects, but we're going to briefly talk about these 5 top ones. These are weight gain, glucose or diabetes, osteoporosis, blood pressure, and heart disease. And if you look at the agreement on most important side effects between patients and rheumatologists, the box on the left rates the top 5 side effects that patients consider important when they're on steroids, these being osteoporosis, heart disease, diabetes, weight gain, and high blood pressure. And the box on the left is what we as treating physicians think of it. And if you look at it, the order might be different, but it's generally the same, with the exception of one. Weight gain seems to be much more important to the patients, while infections are much more important to the rheumatologist. So just talking about weight gain, this is a 67-year-old female. So as I started gaining the weight, like my size went up. I've been a size 6 for my entire life, and then all of a sudden last summer, when I went to get my summer clothes, nothing was fitting me. It was everywhere, like upper arms, and then like my shoulders puffed up, and my face, especially because you look at yourself in the mirror every day, and I didn't like what I saw. It wasn't me. And this is a very valid concern. And perhaps we as physicians sometimes don't think about it because we think that weight gain is an expected outcome of steroids, and we don't talk about it a lot when we start patients on steroids, apart from just mentioning that it can cause weight gain among a list of other things. So steroid-induced weight gain is the top concern for patients. In one survey, up to 70% reported gaining weight. 20% gained more than 20 pounds. And the weight is hard to lose, and there's a high retention of the weight gain after you stop the medication. And the most weight gain was gained in patients who were newly diagnosed with rheumatic conditions and who were started on steroids for a new diagnosis. So how can we prevent weight gain? It's a hard thing to do. It's difficult. But some options would be to keep a food diary or a smartphone app so you can take control of your calories. You need to cut down on your portion size. And sometimes it is hard to have this discussion when we're talking about a serious disease and steroids and medications to tell someone you need to look at your calories. But if you start early, we have some evidence that it reduces the amount of weight you gain as compared to starting late once you have already gained the weight. Have a regular eating schedule. Just eat a healthy, balanced diet. I think there's no real evidence to trying different kind of fad diets. It's just you eat healthy, eat less portion, and just try to exercise if you can in whatever way your disease permits. And you have to be persistent. It has to be a lifestyle for you because it will take months to years sometimes to get off that weight that you've gained from the steroids. And then again, as we talked earlier, remember that every person is different when it comes to weight gain with steroids. The next concern that patients have is about diabetes and new diabetes. It's a dose-dependent function, so the higher dose you are taking and the longer you're taking, you're more likely to develop either diabetes or get worsening diabetes. So you have to be aware of what are the signs and symptoms of high blood sugar. You have to modify your lifestyle, just we talked about earlier, maybe cutting down on calorie-rich sweet foods. Have a regular glucose check if you already have diabetes. And then if you do develop these symptoms, treatment would be similar to diabetes. And generally, it will resolve after steroids are stopped. So that's the good end result, hopefully. Long-term steroid use weakens bone. So that is a very important thing to understand here. So this is just a figure which shows a cross-section of the normal bone. So this is how a normal bone looks like. It's pretty compact. And then we have osteopenia, which is thinning of the bone. So it's not normal bone. As you can see here, the compactness is reduced. So this is also a disease state, especially relevant for people who are on steroids. And then we have osteoporosis and then severe osteoporosis. Another thing to remember, some people confuse osteoarthritis with osteoporosis and osteopenia. So osteoarthritis is just wear and tear arthritis, bone and bone disease, and osteopenia and osteoporosis are very different. So once you start steroids, you have a rapid decline in your bone density, up to a 75% loss at 3 months. And it can be independent of patients' pre-existing factors. So even if you're totally healthy, you are most likely to lose some bone mass. And the higher dose you are on and the longer you take it, more damage. It is also very important to understand that many people have had have not had a bone density, but some have had a bone density and they have been told that you have osteopenia. And it's assumed that osteopenia is something not very serious. But when you're taking steroids, osteopenia is very serious. Most of the fractures occur in patients who have osteopenia, just because osteopenia is more common. So when you have osteopenia, you have to talk to your primary care doctor or your rheumatologist or your endocrinologist to calculate a fracture risk. And then if your risk is high, you have to be on some medicine to prevent osteopenia and osteoporosis, even if you don't have frank osteoporosis on bone density. Because if you don't treat it, you will end up having fractures, which sometimes can be silent. And one always thinks of fractures being very painful, but you can have spinal fractures and never know about them. And then, of course, you can have the more serious fractures, wrist fractures, and most importantly, the hip fractures, which is very serious, long-term recovery, and higher mortality. So it's very important to focus on the bones. Every woman postmenopausal who has a rheumatic condition should, I think, have a baseline bone density done. And if they are starting treatment, the bone density should be done very soon, within the first 2 to 3 months, if not sooner. So what can we do to prevent bone loss? So risk factor evaluation, if you have a family history of osteoporosis, if you are thin, Caucasian lady, early menopause, and all those things that you can discuss with your doctor or your doctor should look into. If you report height loss, that is an indirect marker of osteoporosis, because if you compress your vertebrae or you fracture your vertebrae, your height will go down. So if you lost more than an inch of height, I think it's important to get a bone density done to see where your bones stand. And then you get a bone density or DEXA scan like we talked about. And then I would like to reinforce that you should be screened and treatment should be started. And if you know that you will be on steroids for long term, you can start treatment even before getting a bone density, as the treatment will not impact the bone density results in the short term. Calcium and vitamin D is good to take as a supportive measure. It is not the answer. It will not prevent osteopenia or osteoporosis. Steroids do cause some calcium to be lost through the body, so that can help it, but many people would think, I'm just taking calcium and vitamin D and I should be fine, so that is not correct. Lifestyle modifications, again, exercises to build your core, keeping active, eating healthy, and then trying to do some fall prevention. So your houses, especially for the elderly, should be fall-proof. Night lights, no loose carpets, and other things like that. Bathroom stands to get up, etc. And then pharmacological treatment. And that is typically Fosamax. And I'm sure many of you have heard that name. And there's a lot of misunderstanding about Fosamax. A lot of patients don't want to take it because they've heard bad stories about it. Typically, that it can cause necrosis of the jaw, or it can actually cause fractures in itself. And while true that these can happen, these are extremely rare. So if you are on steroids, and if you have osteopenia or osteoporosis, you are much, much, much more likely to fracture than to get a side effect. So, for example, we need to treat 4 patients with Fosamax to prevent 1 fracture in the spine, but we need to treat 50,000 patients before we get 1 side effect of the necrosis of the jaw. So the odds are really very different. So we should not discount such treatments. Steroids can worsen blood pressure and heart disease. So heart attack about 2.5 times more common in those who take 7.5 milligrams of prednisone or higher dose. Their effects on cholesterol is a little bit controversial. It's also unclear how much the underlying disease contributes to the inflammation versus the prednisone itself contributing to the atherosclerosis. So I think the bottom line would be just to monitor and manage the risk factors as for every patient who has these conditions. And just be aggressive with your target blood pressure, glucose, lipids, etc. So as discussed earlier, the major concern is infection risk, and this certainly can cause infections. These can be typical infections, and then these can be opportunistic infections, as was mentioned by Dr. Specs in his talk, especially a certain kind of pneumonia called a PCP pneumonia. So you should have prophylaxis against that infection if you're on long-term steroids, and also if you're on rituximab or cyclophosphamide. You can have that discussion with your doctor. But this is an infection which has high mortality, so it should be considered seriously. And then general vaccinations. So if you look at this graphic here, this is the general US population. The vaccination uptake, only 45% get influenza vaccines, 23% for pneumonia, 31% for shingles, and 23% for tetanus, which is very low. And this has to be very high, especially for patients like you who are on multiple immunosuppressive medications. So they are critical for preventing infections, including influenza, pneumonia. And then for pneumonia, there are two types of vaccines, and you should get both of them in sequential order. And then, of course, shingles, which is, again, a major disease that can be seen in patients who are immunosuppressed. So can you get vaccines while on steroids? Certainly you can. What about live vaccines? So you can get live vaccines, but if you're taking a steroid dose of 20 or higher, then they are usually not given. The only live vaccine pertinent to rheumatology is shingles, and now we have the non-live version, the Shingrix, available, so that's probably not a big concern anymore. And then, do vaccines cause autoimmune disease flares? So we never say never in medicine, but it is extremely rare, and as a general rule, they do not cause your autoimmune disease to flare up. So vaccinations should be pursued. Another thing that's very pertinent to patients is skin damage. So a patient said, my skin is like tissue paper. I'm cutting the grass, I brush against a shrub and look down, and I'm bleeding like a pig. And this is a true reported side effect, and this can present in different ways. You can have a thin skin, easy bruising, poor healing, and then you can also develop these stretch marks or striae. I guess there's not a lot that you can do on your aspect to prevent these except for being more careful with what you're doing and bumping into things. This can be prevented if the weight gain is reduced, but these are generally permanent and they don't go away. So what dose should you take that will prevent these side effects and control your disease? So there's no real answer for most of the patients, but if you look at this spectrum, so this is 0 milligrams of prednisone, and this is 15 or higher, there's general consensus that as long as you're between 0 to 5, the benefits are more than the risks with steroids. And then if you are between 10 and 15, then the risks are higher. And this is sometimes a kind of a gray zone. So the actual level of harm is patient-specific, as we discussed. So it depends on what risk factors you have from before and how are you responding to your treatment. So the goal would be to use the lowest possible dose that you can for the shortest period of time without negatively affecting your disease. So general principles, lowest possible dose for the shortest possible period. Understand the side effects can be very variable. And I think it's important to know what to expect when you're embarking on this journey with the steroids. Try to take these preventive and corrective measures, which may sound overwhelming when you're diagnosed with this serious disease with so many medicines and other conditions to consider. Try to reduce your caloric intake as soon as the steroids are initiated, and then try to stay current with health screenings, blood tests, and vaccinations. And hopefully, with the advent of new medications and the new studies showing that we can do the same level of good or benefit with lower doses of prednisone, hopefully these side effects will go down in the coming years. So it's a compromise between you and steroids. I would love to be off the steroids completely, and maybe that will happen eventually, but I think from my experience at the moment, maybe a maintenance dose is the way to go. So that was all. Thank you. Questions?
Okay, thank you. Excuse me, doctor, you mentioned Fosamax or some other bisphosphonate. How long do you need to be on one before they lose their effectiveness in preventing osteoporosis? Is there a time frame of only a couple of years, and then after that it becomes uncertain how effective they actually are?
That's a good question. So for Fosamax and the other bisphosphonates, we have data for up to 10 years that they can be used for up to 10 years and they will still be effective. But not every patient needs to be on them for 10 years. So 5 years is the general rule. And after that, it has to consider what your bone density is, what your fracture history is, and then it is a discussion between you and your provider whether you want to do another 2, 3, or 5 years. But generally, the duration you're on the steroids, you have to be on it. And then even afterwards, especially if your bone density is low or if you have osteopenia or osteoporosis. Okay.
Yeah, hi, back here.
Oh, sorry.
So I've been on prednisone for about 13 years now, and I've reached the point where I'm stuck at a 10 milligram dose because of secondary adrenal insufficiency. Other than managing the side effects, do you have any kind of ways to help manage that, ways to maybe help improve that so I can try to taper again? Because like you were saying, 10 milligrams, 15 milligrams, you're getting into dangerous territory. And there's a lot of us who are stuck at that dose or higher indefinitely.
Yeah, I think that's a very valid question. I think it's a difficult situation. If we've been on steroids for such a long time, not only, as you said, you're adrenally insufficient and you need the steroids, but I think your body is also adapted to the prednisone in other ways that once you start going down, you experience pain and other problems. And at least on my personal level, I've had variable experience. If you do a very, very slow taper and then work on other factors that are contributing to the disease, which would not just be the disease, but other things like associated chronic pain conditions and focusing on those. And if you have fibromyalgia, focusing on those, that it may be successful. But a really slow taper to the lowest possible dose that can work for you might be the answer, but nothing definite, yeah. Yeah.
I think you just answered my question.
Okay.
I just have found reducing the prednisone is extremely difficult. And it bounces up and down, the amount. If I'm getting an infection, doctors that I've had in the past would increase the prednisone. And I'm seeing on your slides that the steroids might actually cause an infection, which I hadn't seen that before. So I really am wondering how you ever just get off of it.
Yeah,
I've been on it for 6 years, so I don't know.
Yeah, no, it is hard. And sometimes in infections, for example, COPD, they would give you steroids along with the antibiotics, so that's part of standard treatment. But yes, it is challenging sometimes, for sure.
Yeah, question. Yeah, I have a question about, is there a cumulative effect of steroids over time? In other words, if you stay at that low level, but for 5 or 10 years instead of just 2 or 3, what would be the basis of that cumulative damage?
So for some side effects, some side effects are dose dependent, for example, edema or weight gain. And some are a threshold dependent side effect, for example, mood changes or irritability. So it depends on the side effect. For some, you will get it after a certain dose, but not before it. And for some, as you said, if you've been on it for long term, you'll get those. So for example, cataracts, glucose, weight gain will all be dose and duration dependent, even if it's a lower dose. Yeah.
Have you heard of something called steroid psychosis? And if so, is there like a threshold that would set?
Correct. So the understanding is that steroid psychosis is a threshold dependent condition, and the threshold is of course different for every patient. And it is a major problem for patients, and some of the patients are really sensitive. Sometimes we have seen that if you switch this prednisone to a different version, like methyl prednisone, the psychosis tends to be a little less. But again, it has to be tried before we know whether that will be true for that patient or not. Yep. Behind you?
I have another question about the Fosamax.
Sure.
If you have an autoimmune disease and you take that, are those side effects, the fractured jaw, do you have a higher risk for that?
No, actually, so
No.
if you, for the fractured jaw, the risk is higher if you have a malignancy, for which the Fosamax or the equivalent doses are much higher, or if you have a very poor dental hygiene, or if you have major procedures planned, that would be the risk for having that osteonecrosis. But otherwise, if you're in good dental health, then it shouldn't be a problem.
Okay.
All right. Thank you.